Okay, so I'd like to introduce our next speaker, Felicia Woods, who is the Executive Director of the Cancer Policy Institute at the Cancer Support Community, where she is responsible for all aspects of the Cancer Policy Institute, including the legislative, regulatory, policy, and research priorities. She's primarily focused on health disparities, psychosocial care, and emerging sciences and clinical trials. Previously, Ms. Woods was a director of federal relations at the American Cancer Society's Cancer Action Network, where she developed and executed strategies to ensure that federal legislation promoted access to preventative services and quality, and also affordable care for people impacted by cancer. Formerly, Ms. Woods was counsel to former U.S. Senator Claire McCaskill. Before working in the Senate, Ms. Woods served as a Peace Corps volunteer in Swaziland and a legislative assistant to former U.S. Congressman Russ Carnahan. Ms. Woods earned a Juris Doctor at the University of South Carolina School of Law and a Master of Social Work and a Bachelor of Arts in Psychology from St. Louis University. Thank you so much for presenting for us today, Felicia Woods.
Thank you for that kind introduction. I'm going to share my screen, so if you can give me a few seconds to pull up my presentation. Appreciate that. All right, let's get to the beginning now. All right. I think we're good to go.
Yes, ma'am, you're good.
Okay, cool. All right, well, good afternoon, everyone. Again, I'm Felicia Woods, Executive Director of the Cancer Policy Institute at Cancer Support Community. And I'm very excited to be with all of you and also excited to follow such a dynamic group of women on this panel talking about a very important issue, which is pain policy. And they've pretty much just set the stage for me and bringing this culminating piece where we're focusing on policy and advocacy and how we can do more in the pain management space. So with that, before moving forward with today's presentation, I want to provide some background on CSC, my organization. It's good to virtually see some of the participants from CSC on here, as well as those from Gilda's Club here for the presentation. CSC is guided by our mission to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We are focused on the psychosocial well-being of patients and look beyond physical symptoms to what affects patients, caregivers, and their loved ones mentally, emotionally, and financially, and so forth. We are the largest professional-led nonprofit with about 50 affiliate partners in over 175 locations. Specifically, we deliver a comprehensive menu of personalized and essential services at no charge to everyone diagnosed with any cancer and to his or her loved ones. As mentioned, I lead the Cancer Policy Institute at CSC, which proudly and boldly uses our 3 pillars, as you can see on the screen: patient services, insight, and advocacy to serve our community through engagement in public policy and advocacy at both the federal and state levels. We have become a leader in advancing the evidence base and promoting patient-centered public policies to ensure that the patient voice is at the center of the national dialogue. So the focus of my presentation is to really help you understand and see the importance of advocacy and how it shapes policy and ultimately leads to breaking down barriers, dismantling persistent systemic issues, while creating thoughtful transformations for all people. My hope is that after our time together, you will gain a deeper understanding of the current policy landscape regarding pain management and why cultural competence, social determinants of health, and community engagement and education of policymakers are instrumental to building a united advocacy agenda focused on eliminating disparities in pain management. I'll first walk you through how personal stories are influential in changing policy, and then discuss the current landscape and outline the need for more advocates. So essentially, this presentation is a call to action in advocacy. I'll start with my own personal story. I firmly believe policy must connect with the people. The real world issues that people manage on a day-to-day must be accounted for when we're shaping policy, whether it's big P policy or little p policies. The human element of a data point or statistic must be considered in determining all policies. And what do I mean by that? A person is behind each data point, a person with a unique story, or a person who has led a life prior to being diagnosed with cancer or any other chronic disease, illness, or syndrome. Fully accounting for the person and the qualitative aspect of data is integral in advocacy and policy. Personal stories should drive policy-centered dialogue. Personal stories bring a face to a cause and humanizes an issue. As I tell my story about Phil, I want you to think about your own personal stories. Who are the patients that you are currently serving or have served? What community or communities do you provide services in? And how can you use those personal stories of being a provider, a social worker, maybe even a patient, family member, or caregiver in advocacy to reduce biases against communities of color as it relates to pain management? Now, Phil is a 63-year-old Black male who lives in Memphis, Tennessee. He retired from 40 years working as a skilled laborer in a manufacturing plant. He worked nearly 6 days a week, 12 hours a day, running machines and on his feet all day long. Since the age of 55, Phil has been living with chronic pain. Daily, he suffers from severe headaches, to numbness, tingling in his spine, stiffness in hips and legs, and back pain. While Phil does not have cancer, there is a history of colorectal and prostate cancer in his family. And for those reasons, I want to highlight his story. He is cognizant of this history and does his best to stay up to date on his screenings. But despite his chronic pain, Phil maintains an active life. He spends his retirement working to rehab homes, is an excellent craftsman, and also an excellent baker. Phil has been to several practitioners for the last few years for his pain, including neurologists, general practitioners, orthopedists, you name the specialty, and Phil has been to them seeking answers for his pain. He has had several MRIs, undergone cortisone treatments, and been prescribed copious amounts of prescriptions for opioids and muscle relaxants, all to address this pain. However, in all of these doctor's visits, nothing has frustrated him more than not being heard by his providers. While he has had some procedures done, such as MRIs and X-rays, the source of his pain has yet to be figured out. It took numerous doctor's visits for his practitioners to honor the request for these specific procedures. Keep in mind that he has been in pain for about over 10 years, so since the age of 65. And only a year ago his doctors did an MRI to determine the source of his pain. He was diagnosed with spinal stenosis, but his pain persists. Phil is hesitant to take the pain meds and muscle relaxants because he fears becoming addicted. Also, these medicines make him extremely lethargic and unable to keep up with his active life. He has asked his doctors for alternatives, if there are other ways to treat the spinal stenosis, and can his pain be treated without meds or surgery? His doctors are refusing to work with him to determine a better solution. In preparation for this presentation, I chatted with Phil to see if there's been any progress with treating his pain. And he informed me that the doctors don't believe that holistic methods are necessary, only surgery can relieve him. But he fears that surgery on his back could cause irreversible harm. He simply wants to relieve this pain, and he simply wants physical therapy to do it. But he also said he doesn't think an insurance company will take him seriously about his pain, and they definitely won't cover physical therapy because to them, pain isn't a big deal. Despite all of this, Phil trusts his doctors because they are the experts. Simultaneously, he feels these doctors have failed him. He does not feel educated enough or powerful enough to ask the right questions to get the treatment that he desires. So in our conversation, I subsequently asked if he had hope that one day he would be free of pain. And he said, and I quote, "I've resigned that I will forever be in pain, and there's nothing that I can do but accept it and live through it." I know Phil is not alone, and there are more people who can identify with his thoughts and his pain journey. So as we progress through talking about biases in pain policy, I just want you to keep Phil's story in mind as we move forward. So some of the bias in pain policy: pain is a public health issue that has serious social and fiscal consequences. The issue of pain goes beyond the treatment of a disease and different methods for treating disease states. According to pain policy experts, chronic pain is strongly associated with societal costs measured in terms of disability, poor quality of life, relational problems, lost income and productivity, and higher healthcare utilization, including longer hospital stays, emergency room visits, and unplanned clinical visits. Now, even though chronic pain has tremendous socioeconomic impacts, pain care, training, and research are traditionally not invested in. About 1% of the National Institutes of Health's research budget focuses on pain and symptom management research. Significant racial and ethnic disparities exist throughout the healthcare setting, and we've heard from all of our speakers about these inequities that exist. And so they're reflected in disparate pain care outcomes. Widespread racial and ethnic disparities in pain assessment and treatment exist across settings for all types of pain. We're talking about acute pain, cancer, or any type of chronic non-malignant issue. But pain is assessed differently in terms of treatment for people of color who are less likely than their white counterparts to receive medicines such as opioids or painkillers in all healthcare settings, including emergency departments, inpatient and outpatient procedures, community health centers, and nursing home settings. For people of color who are uninsured or underinsured, that creates another structural barrier to getting appropriate access to pain care and treatment. Moreover, in an effort to contain costs, insurance policies can perpetuate biases when it comes to accessing pain care. For example, reducing or containing costs is a common topic amongst a variety of stakeholders. Some decision makers, like insurance companies and pharmacy benefit managers, use utilization management techniques as a primary cost containment strategy. And these decision makers focus on medical necessity, appropriateness, and efficiency of the use of healthcare services, procedures, and facilities under the provisions of an applicable healthcare plan. The techniques create barriers alone for those who are underinsured, and to those with any insurance, these tactics can result in failure to reimburse services and also failure to allow for medications despite the clinical or cost efficiency. Those techniques or policies directly impact people of lower socioeconomic status and people of color. And these people tend to have less access to pain specialists that may be outside of their network, and they're also held to stringent referral processes. So thinking back to Phil's story, where he shared, insurance companies don't care about my pain. These practices are well known amongst communities and part of the reason why some people may not seek out treatment. So since the Affordable Care Act, and also in response to the opioid epidemic, Congress has paid more attention to pain management. Policies focused on pain management were implemented as a result of the ACA. Multiple ACA provisions implemented provisions related to training, such as to reduce inequities in pain care. The ACA increased recognition of pain as a public health problem in the US, developed evaluations and assessments for diagnosing and treatment of pain, supported disparities in pain care research, and also supported plans to reduce barriers and improve education and research into clinical care. And lastly, training providers in pain care about culturally and linguistically appropriate services. Training primary care physicians in cultural competency, and developing and evaluating models of cultural competence curricula while supporting collaborative research on topics that include culture. So in respect to the opioid epidemic between 1999 and 2019, nearly 500,000 people died from an overdose involving an opioid. And I won't go through the entire opioid epidemic, but really just trying to draw a picture here. As I said, nearly 500,000 people died from an overdose involving any opioid, including prescription and illicit opioids. And in response to the opioid epidemic, federal and state policymakers focused significant attention on ways to curb the epidemic. And hundreds of opioid-related bills were introduced in Congress. Several congressional hearings were held about the crisis, focused on drug enforcement, strengthening existing laws, treatment, and recovery. The increased legislative and regulatory activity with regard to opioids was aimed to tighter controls and increase education in the use of these drugs. While many stakeholders fully supported these efforts to address the misuse and abuse of opioids, there was strong concern among stakeholders about how broad policies could have unintended consequences that limit access to pain care for people with chronic illnesses like cancer, and could also further exacerbate the racial and ethnic inequities in the delivery of pain care. Though not all cancer patients or those with chronic pain require opioids for treatment, we all know that pain left untreated can lead to worse health outcomes and lower quality of life and quality of care. Stakeholders advocated for balanced solutions that would not have adverse consequence on patients in need of medical treatment. And as a result of comprehensive legislation to address the opioid epidemic, prescribing rates of opioids, unfortunately for cancer patients, had declined. And some of these measures that have been enacted have made it harder for opioids to be obtained by people living with chronic illnesses, and have prevented some doctors from really prescribing appropriate amounts of opioids to their patient population. Now, adding all that up, this also lowers access to prescription opioids and medications for Black people and contributes to at least two adverse outcomes, such as the potential for severe undertreatment and mistreatment of pain for many communities of color. And the data shows that Black Americans were not protected from this epidemic because underprescribing in many cases may have led to life-threatening consequences for people affected with pain disorders. Now, moving towards the PCHETA legislation, as is affectionately called on Congress, but it is the Palliative Care, Hospice Education and Training Act. And I've appreciated that all of the speakers have talked about palliative care and the need of palliative care. This bill has been introduced in the House and Senate for several Congresses now. And there's tremendous bipartisan support of the legislation. However, the legislation has yet to pass. And I'll talk to you a little bit about the legislation. As we know, palliative care and hospice can play a significant role in creating lasting changes across the healthcare system. PCHETA would be used to expand the interdisciplinary palliative care workforce. And when I say palliative care workforce, we're talking about providers, social workers, chaplains, faith-based institutions, nutritionists, all the people that work as a team to help provide services to the patient, both treating the underlying disease, but also looking at the psychosocial impact of a chronic illness. PCHETA would promote the awareness and benefits of palliative care among patients and providers and improve the evidence base for this care. Delivery of high quality palliative care cannot take place without sufficient numbers of healthcare professionals being appropriately trained and provided the skill set to do palliative care. And right now, students and graduating from medical and nursing schools have very little training in palliative care and very little training in pain and symptom management. So with that, PCHETA could go a long way in bridging the gap between establishing education centers and career incentive awards to help people understand the importance of palliative care. Now, I talk about palliative care, and I'm sure you're probably wondering why I'm bringing up PCHETA. Well, during the opioids debate and while the legislation was being formalized as to how to address and curb the epidemic, advocates lobbied Congress to include PCHETA in the legislation. So PCHETA would be used as a great complement in the opioid legislation as it seeks to create a balanced way of expanding pain and symptom management training for doctors, nurses, pharmacists, and others who treat patients with serious illnesses and chronic and acute pain. We need balanced policies like PCHETA to be adopted to not only address the opioid epidemic, but also to make sure that there are not unintended consequences when Congress steps in to enact sweeping legislation to address societal issues. Currently, PCHETA has not passed Congress, and it is our hope that as we begin to look in the new Congress, in the 117th Congress, which is where we are right now, that there is opportunity for this legislation to pass. So my hope is by talking to you about this legislation, that it helps you see the importance of advocacy and why we need more providers who are similarly situated as yourselves to raise the awareness of legislation like PCHETA, or legislation that really creates balanced policies that can help affect change in communities of color, but also in the communities that you specifically serve. So I just want to talk to you a little bit about my work when I spent time working on Capitol Hill, and why a lot of the personal stories that I've really been trying to weave into this presentation are so important. When you think about working on the Hill and hearing from patients, hearing from providers, hearing from the community, oftentimes I enjoyed those conversations because they helped me talk to my senator or my representative about what's important to the people on the ground, the people who have their finger on the pulse of the issues that are relevant to the communities that politicians serve or that policymakers make decisions for. The patients are the ones who have the expertise, as well as the providers, as well as the social workers. And so for me to go to my boss at that time, I would have to say, I think we should support this legislation because it would be beneficial to patients, or I think we should oppose this legislation because it would cause unintended circumstances. So having the knowledge of being a provider or being a social worker or community liaison, married with your personal story and using that as advocacy really builds the case on why it takes true advocates like yourselves to make systemic changes within our system. So to be successful in addressing pain and any initiative, we must focus on improving pain care for racial and ethnic communities and those who are experiencing vulnerabilities such as lower socioeconomic status, or living in under-resourced communities. It is also equally important that the medical community, in conjunction with patient advocacy groups and patients, take the lead in developing a concrete agenda on addressing health disparities in order to leverage national initiatives to really make fundamental change. Policy measures that make it harder for patients to access much needed treatments are not the solutions that we need to be focusing on right now. There's so much appetite in the community to create change, and we need to use our public health lens as well as our preventative lens to really look at the issues that are causing the systemic issues that are creating these barriers to getting access to treatment. So next, I just want to talk to you about eliminating pain care disparities and how we can create a united advocacy agenda. So many of the existing gaps in care go back to a historical lack of research focused on pain experiences and of treatment, including racial and ethnic groups. That includes Black, Middle Eastern Americans, Indigenous peoples, Latino and Latinx, and Asian Americans. A 2019 review of existing disparities in pain experiences and treatment among racial and ethnic groups shows that there's a complex interplay between the patient and the clinician. And compared to white people, the review found that patients of racially diverse backgrounds have their pain traditionally underestimated by providers. They receive less comprehensive diagnosis and have less access to pain medications such as opioids. The medical community, as well as policymakers, have a duty to be more sensitive to inequities and to diagnosing and treating pain. And to achieve that, I suggest more of a focus on understanding the impacts of the social determinants of health, being more culturally competent, and using community engagement, which all of the speakers have spoken about, and weaving that together to educate policymakers about the issues facing communities. You know, where a person lives, works, and plays is all part of the social determinants of health, but there needs to be more of a focus on the vital conditions of health when we are looking at pain policy and policy in general. And those vital conditions of health really focus on, is there reliable transportation in somebody's community? Is there clean air? Climate change is a big issue as it relates to healthcare. Is there humane housing? Basic needs that are being met to really help people understand where the community is coming from and how to meet the needs of the community. As well as looking at cultural competence, patient and provider interactions during assessment and treating influence health outcomes. These health outcomes can become worse if there's implicit bias or stereotyping amongst healthcare professionals in treating people of color, which can also exacerbate unequal treatment of pain. And so community engagement, which we talked about and Dr. Noel really highlighted, and I'm just grateful for what she specifically said and how we can show up in a community. But when we show up, we should be active listeners. We should talk to the community about what they're doing to educate their communities. Who are the essential leaders in the community? How can we engage with them and meet them where they are? And first, by establishing that trust. The social determinants, the cultural competency, and the community engagement, as you add all of that up, you become more equipped to be a more effective advocate in educating policymakers. I believe while advocacy organizations serve as a catalyst for addressing the undertreatment of pain, the issue of disparities in pain care is not explicitly articulated, usually in broader missions when we're trying to address pain care management. So with a lack of a united agenda where every stakeholder is present, the issues of disparities in pain care is still undercut and unfortunately not really taken seriously in some professional standards through increased provider education and just in patient and system outcomes alone. All advocacy groups must advocate for the elimination of pain care disparities and improve access to evidence-based treatments for all patients, as well as develop a united front when talking to policymakers, and I mean at the state level, the federal level, and local level, but also institutionally on how to address the issues facing the community. So I just want to revisit Phil's pain journey. So at the beginning, I asked you to think of your own personal stories. Who could you advocate for and uplift when shaping policies at your respective organizations and within your respective communities or at various levels of government? Oops, sorry, I'll go back. Moving too fast. Hold on one second. And so there are countless patient stories that I could have pulled from today to illustrate my point. But I chose Phil, who is my father, if you can't tell by the resemblance, as he is the primary reason why I work in advocacy. Like him, several members of my family live with chronic pain and illness. Additionally, some have survived cancer, while unfortunately some have succumbed to the disease. Their personal stories are etched into my heart. And as we lean on personal stories, we become better advocates who seek out policy solutions that disrupt and dismantle systemic norms that have caused inequities while we are increasing access to and affordability of care and promoting patient-centric policies that acknowledge, include, and uplift all communities while educating patients on how to use the power of their personal journeys to be the voices of change in the system. In our nation and globally, the moment has passed for symbolic and performative gestures to address longstanding systemic issues. We must collectively turn the tide as it relates to systemic racism and decreasing inequities in the delivery of healthcare and pain care. And in doing so, we need to examine current biases and then move towards developing and implementing culturally sensitive, patient-centered approaches to care throughout our healthcare system. So with that, I'd like to thank you for the opportunity to present about advocacy. And I hope that as we finish this presentation, that you all take more of an interest in advocacy. And I would love to talk to you afterwards about how to get you active in the advocacy sphere. So thank you for the opportunity.
Oh, Felicia, thank you so much. That is so inspiring. How you think about individual stories and then move that to the legislative realm is really incredible. Thank you for sharing all that you did and your dad's story and,
No problem.
Great work. We have time for questions. Again, please put them in the question and answer box if you can. A couple of questions have come in about Pachita.
Mm-hmm.
I ask you those if that's okay. The first one is, can you share insights on policies that examine the need for balanced pain management solutions, such as Pachita? And then the second question related to that, what are the next key steps for getting Pachita passed?
So I'll start with the second question, the next key steps in getting Pachita passed. We need advocates like you. We need you to raise your voice about how Pachita would be beneficial to be implemented. You know, starting off with education of providers and really education of medical students who are interested in working in community settings or working to provide palliative care is important. Right now, I believe only a few hours are dedicated to in medical schools focused on palliative care and hospice care, but also looking at social work. I decided to pursue a degree in social work because of the grassroots aspects of it, the community engagement aspects of it. But there needs to be more of an education there in the social work disciplines to really compel people to understand why pain and symptom management is so important. And so for us, so for legislators, when it comes to Pachita, hearing more about why this education would be beneficial in day-to-day practices is a way to help the legislation get passed. It has not been reintroduced. PCHETA has not been reintroduced in this Congress, but I believe that it will be reintroduced soon because it has enjoyed so much bipartisan support that we're hopeful that it will pass both the House and Senate and become law soon. Now, when it comes to balanced pain policies, it's important to have cancer policies where we really talk about initiatives where you're looking at not creating strict sweeping legislation. After working in Congress, one thing I know is that when Congress responds to a call, it's usually something that's very immediate and sweeping without really taking into account some of the unintended consequences. So having people raise awareness about why you need balanced solutions so that if we do pass, like we did when we passed opioid legislation, making sure that cancer patients still have access, or people with chronic illnesses still have access to opioids without having stigma being attached to them is important. As I shared about my father, he does not want to take opioids because one, he's afraid of being addicted, but also really just going into a pharmacy and getting that prescription, that can cause stigma within the community. So at a federal level, we have to listen to those on the ground about what's really affecting them day to day and raise that awareness a little bit more.
There was a second part to one of the questions about PCHETA, and that was, and this question may go to the larger panel and maybe something we can also talk about in the Q&A, was how can our three sponsoring agencies, AOSW, APOS, and ACCC, what can we all do as sponsoring agencies to help move PCHETA forward? Do you have thoughts about that?
So I believe, and please don't hold me to the memory, but I do think some of the sponsoring agencies or all of the sponsoring agencies are supportive of PCHETA. But I think the sponsoring agencies definitely supporting the legislation is important. But we all live in different congressional districts and states. So we all can send letters to our members of Congress or to our senators expressing our support. Yes, the sponsoring agencies can do it as a collective or write letters, but you as an individual have a right to reach out to your member of Congress and advocate on behalf of the people that you provide services to elevate their voice. Also, you have a right to talk to the people in your communities about the importance of grassroots advocacy and elevating the people's voice. I think from working in Congress, one thing I know, when a member hears from their constituents, their ears are in tune. They're listening to them because they have to go back to those communities and those town halls and answer questions. And the last thing you want to do is have a constituent write in and you don't thoughtfully respond to their specific issue, or at least hear them, because that's what we really want to be heard in many of these communities that unfortunately are traditionally unheard.
That's great. So another question has come in. What are the current policy challenges related to pain management?
So I think some of the policy challenges related to pain management, we're still in the throes of trying to understand and answer the questions about the opioid epidemic. Much of the legislation that passed in 2018 is undergoing the regulatory process. There's also a lot of lawsuits out there in response to the opioid epidemic too. I think right now, the challenge is making sure that we don't swing the pendulum too far and come up with ways where we can make sure that we're answering the issue as it relates to misuse and abuse, but also ensuring that patients are protected and kept first and at the center of dialogue. And in order to do that, we have to be actively involved in the process, even at the state level, when money is being given to states to come up with policies and procedures to manage the epidemic. So having thoughtful providers like social workers and those in the other medical communities reaching out to state legislators about, well, how can I get involved to make sure that we're keeping this conversation balanced and not swinging the pendulum too far that we're causing unintended consequences.
Seeing if there
So this is just my plug for grassroots advocacy.
Again, this might be something we want to talk about in the larger panel discussion, but this issue of, engaging communities and advocacy sometimes can feel so big and daunting for some of us.
Yeah.
I think you've been answering this already, but what would you say to the person who asks, I'm just one person, what can I do?
Well, I would say one person, it's kind of like, so I started off, just a little history about me. I started off doing voter registration in St. Louis, and just as a person who stood at bus stops registering people to vote. That's how I started off with community organizing. And people would often say to me, I'm just one person, my vote doesn't count. And I'd say, well, if 10,000 people came to me and said, I'm just one person, my vote doesn't count, that's 10,000 votes that an individual who could be a phenomenal candidate loses and can't make incremental change. So I would use that example here. If you say you're one person, my advocacy letter doesn't count, what if 10,000 people say the same thing? Those 10,000 voices can count. We have to look at it as though you're one who's also part of a collective. And as you raise your voice, your family member raises their voice, or your person at your church may raise their voice. And together, all of you as a unit and as a community can create effective change. So you're not just one person, you're one amongst many who can truly make significant, tremendous strides. And I know that advocacy can be very much so, as you said, daunting, and it can be hard to do. But I realize the societal impact of it, and how a lot of the changes that have been made in our world has been because one person connected with another person, and so forth, and raised that collective voice.
Do you have recommendations of how to do this within organizations, hospitals, care centers? What would you recommend there?
So I think the sponsoring agencies also have some grassroots organizing. I would get hooked up to patient advocacy organizations like Cancer Support Community. We run a grassroots network where we send out letters and asking people to email their members of Congress. So I'm happy to drop our action alert in the chat, and that way, you can get connected on a local and federal level to advocate for change. That's an easy way to get connected. Oh, Eukarya beat me to it. Good to have colleagues on the call.
Okay. All right. Well, that was terrific. Thank you so much for all that you shared. It's very inspiring and amazing work.